So to help Victoria and myself today, we have we have assembled a very nice team, and so feel free. This is a PCR session, PCR education type. So we are all here together to share our experiences. So there are no teachers and students. We all have experience. It's all about understanding how we can make sure that at the end of the session, you come back home with everything you need just to improve your practice. So please, if you have anything in mind, populate it through the app or raise your hand or use one of the microphones and we're going to answer your question. The learning objectives today are to review the clinical outcomes and patient benefits observed in the recent mitral and tricuspid TEER studies. The second is to debate all together how the real-world experience fits in randomized clinical trials performed on mitral regurgitation and tricuspid regurgitation patients. And at last, we will discuss the contemporary clinical practice for durable and successful TEER patient management through a live-in-the-box case and the presentations that you're gonna see. So as I said, we have assembled a very nice and very open-minded panel. So feel free to get to us and to integrate the discussion. Apart from Victoria moderating the session with me, we have Tiffany Patterson, Francesco Maizano, Ali Vazir, Wojciech Wojakowski, and you can see the lecturers that are going to come one after the other one just to share their experience. So having said that, I guess we can kick off the session with the first lecture.
So it's my pleasure to introduce Dr. Fernando Sarnago from Madrid. He will speak about the new emerging evidence in tricuspid TEER.
So hello, good afternoon. Thank you everybody and also the organization for being here. So I'm going to go briefly through the latest evidence in the tricuspid side, mainly two studies, the TRILUMINATE and the BRIDE studies. This is my disclosures. Starting with the BRIDE study, just this slide quickly to show you that we've got really good results in terms of TR up to 2 years. If you see the difference between the first year, which already all of you knew, and the results at 2 years, they maintain very good results, and these just translates into good results in terms of functional class. Also, the other thing I'd like to point out is that in terms of adverse events, once you just have gone through the procedure, which also has very low AE, up to 2 years from the first year, there's really minimal new incidence of adverse events in terms of no device embolizations, no more single leaflet detachment, and also in terms of reintervention, you see very low increase in terms of new procedures and no other surgeries beyond the first year. And what about clinical results? Not only just quality of life, we can analyze the annualized heart rate hospitalization rate, and you can see here that the rates before starting the therapy and at 1 year after the therapy or even 2 years after the therapy are really low, and there is an improvement in terms of annualized rates of hospitalization. You can see that we don't have data of all the patients in the registry, but there is a clear evidence in significant reduction in the rates of hospitalization. Also, I think this slide is important just to support that the sooner we do the therapy, the better outcomes we will get. This is not exactly from the BRIDE or the TRILUMINATE trial, but you can see here that when we start indicating the procedure in a patient with severe TR, the results are much better than if we wait till they have massive or torrential TR. Just the same here. So this, I think, translates into prognosis, and we don't have strong data yet, but I'm sure we will have, because if we've got a severe residual TR, the prognosis is much more worse than if we've got no TR or up to moderate TR after the procedure. Going quickly also through the TRILUMINATE trial, you probably all know about the design and the initial data. I just like to point out that after the first year, it was authorized to just cross over and offer the TriClip procedure to the patients, and that up to 142 patients underwent a TriClip after the first year. In terms of 2 years outcomes, here you've got the results in terms of durability of the TR reduction. You can see here the percentage of patients with moderate up to moderate residual TR are pretty high. And also in terms of quality of life, it's maintained through the 2 years duration of the study. And in terms of those patients who underwent the crossover, I'd like to point out with this slide that even though initially the patients were equal, when the investigators or the clinicians that took care of those patients decided to cross over those patients were in a bit worse status than the patients who didn't underwent a crossover. You can see here a much higher percentage of NHA class 3 or 4, and also the percentage of torrential TR were much higher. So if we go to some harder endpoints like hospitalization due to heart failure, you can see here the rates the year before the device, and in that arm it went up to 0.2 during the whole duration of the study. In the patients who didn't have a crossover, it was 0.08 and went up to 0.28 if they were just on medical therapy. And those patients who went to crossover, they had an annualized heart rate of hospitalization before the study of nearly 2. When they considered the procedure, it was up to 0.5. Those patients underwent hospitalization much more. And after the procedure, even it was done a bit late, those analyzed heart rate decreased. You can see here also in terms of TR reduction that patients who underwent crossover, even it was late, the reduction was good. And at 2 years, we had 80% of the patients with less than severe TR, not seen in patients under medical therapy. And in terms of quality of life, you can see here that those patients who underwent crossover were really bad at 1 year. And after the procedure, again, even though it was a bit late, they still improve. Not as much as those who received the therapy at the first time, but they still improve. So these are my conclusions, just to give some time to the discussion. I think are the 4 take-home messages. The therapy has shown safety in terms that the adverse event rates is really low, and we nearly see no adverse events after 1 year. The efficacy, I think, is demonstrated here in terms of quality of life, and also there's data supporting a reduction in hospitalizations due to heart failure up to 2 years. So we can speak about durability, and also there's some data suggesting that the earlier treatment is associated with better outcomes, because we will probably have more technical success and probably better prognosis. And that's all.
Okay, thank you very much. So these were really reassuring data, talking about the safety of the procedure and the potential impact in terms of patient-reported outcomes. And the quality of life is something. The hospitalization for heart failure is another one. There is maybe one point that we can discuss to start is the first question to you is how applicable are these results to patients in daily practice? Because this is first a registry with somehow kind of selected patients, and second, a randomized trial. So how do your patients fit within this, the registry and the randomized trial?
Well, as you said, I think the registry is really a real-world study with real patients. They were old patients, probably a lot of them were a bit in late stages of the TR problem, though the TRILUMINATE is, the population is a bit better. But even though it is a registry and it's not as good data as an RCT, you can see in both the studies that there's a benefit in terms of reduction of hospitalization, which is not only, as you said, quality of life. I think that's starting to have some data in terms of hard endpoints. I think with this data, we should aim to bring the patients earlier to the cath lab. I mean, we need to take them to the cath lab earlier if we want to see some more benefits for prognosis in terms of survival. It will take some time, but if we bring patients earlier, I'm sure we can achieve very good technical results. And I'm a believer that that will give some survival benefit in the mid to long term time.
Yeah, I think that is a very important point, and probably seeing the crossovers from the TRILUMINATE, where you see that the rate of hospitalization, even though you do the crossover late, they remain relatively high. So that points out that these patients may reach a point of non-return. So I would like to see, for example, from those patients that were crossover, what was looking like the right ventricle, or the function of that patient, in order to understand why, despite getting kind of relatively good result with reduction of TR, still they have hospitalization. What are your thoughts on that?
Yeah, I think we should also take into consideration that not all the patients are the same. Probably all of you know that we've got three kinds of patients. You know, the atrial functional TR, the ventricular functional TR, and the ICD lead related TR. When the RV is involved and the RV is depressed, we, as you said, probably have a sweet spot where patients will benefit, but if we wait too much, probably it's we're just reaching futility. So I think for atrial functional patients, we still have more time to think about it, even though I still think the earlier the better. For ventricular functional TR, I think we should very involved in bringing the patients earlier to the cath lab, because if we arrive too late with the therapy, we're probably not doing the right thing.
One thing I would like to hear from you, or whoever wants to answer in the audience, even from the industry partners. Now we have data that shows reduction of hospitalization rate. And that has not been shown before. And this has been shown with maybe some limitations of the crossovers and whatever. On the other hand, evidence of reduction of hospitalization rate brings me to the fact that probably we have some HTA sustainability data that will improve reimbursement across Europe, because one of the main limitations still today of these procedures is to get reimbursement and clinical but also socioeconomic value. Do you think we have enough data to tell our payers that there is a benefit which can be valuable and this can be associated with the reimbursement?
Yeah, I completely agree. I mean, I think we don't have to forget, as you said, this is the only RCT data that we've got against medical treatment in patients with isolated TR, because many people think about other therapies like surgery or whatever, and we don't have really RCTs demonstrating a benefit. And now it's not just a matter of quality of life. With this data, we, as you said, we can talk to the boss of the hospital, just telling them that we're going to reduce clearly the rate of hospitalization, and that's going to be a reward in terms of the cost effectiveness of the treatment.
There is one adjective that comes recurrently is earlier. Maybe we can take the question from the audience. We need to have sharp eyes because you're in the dark. Please introduce yourself, and then we're going to follow your voice.
I need the mic. Okay. I'm Dr. Latibi from Saudi Arabia.
Welcome.
Thank you very much. It's a nice presentation, and I wonder how much of those who could be recrossed after the 1 year, how much of them you think they had RV afterload mismatch? And do you have any data on this?
Yeah, I'm sorry we don't have the data in terms of the, as I said, the differentiation between atrial, ventricular, or ICD lead patients. So I cannot tell you about the RV function of all of them. And I'm pretty sure that the RV function is much more important in those patients with a ventricular-related TR. And in some of those patients, we're reaching the therapy a bit late. But with this data on hand and up to today, we can say that even a bit late, probably we're still reaching some evidence in terms of reduction of hospitalization. So I would say that, just as I said 5 minutes ago, please send the patients earlier. But even if it's a bit late, if there is not a really, really severe depressed RV function, I think we're still on time for reaching some benefit.
I just wanted to make a point from the data that you've shown just now. I think the idea of the medical therapy being effective is clearly, for a selected group of patients, indicates that it's not effective. And this group of patients who crossed over are patients who have progressive worsening of their tricuspid valve regurgitation, which is not controlled by medical therapy. And when you look at the data, there's an increase in the dose of the furosemide that was given to these patients, indicating instability, plus the analyzed hospitalization rates was much higher in the crossover group. So I think this condition is progressive in a selected group of patients. And I think it's very important to phenotype these patients, and I think I'll hand over to the chairs to introduce.
That's a very important point indeed. And so let's move on. Thank you very much, Fernando.
Thank you.
Now it's my pleasure to introduce Dr. Federico De Marco, who will speak about the tricuspid regurgitation phenotypes and patient selection.
Okay, actually now it's the time of the live in a box case. And we will discuss phenotypes while we see the patient. No conflicts of interest related to this presentation. So the patient we have for the live in a box is a 74 years old female, hypertensive, no history of heart failure hospitalization. She has a good EKG with a first degree AVB. No coronary stenosis on the CT scan. The left heart is good with no left side valve disease and a normal left ventricular ejection fraction. And obviously she has severe TR, otherwise she wouldn't be in this live in a box. Her clinical examination shows that she has basically no peripheral signs of congestion, normal cardiopulmonary evaluation. Blood pressure is normal, 6-meter walk test intermediate, 270 meters, and she has symptoms related to shortness of breath with a New York Heart Class 2 since a few months. The therapy is based on olmesartan and 50 milligrams of furosemide daily. Her chest X-ray is normal, normal liver function, a blood test, normal kidney function, and BNP is not significantly elevated. Her tri-score is 1, and her 2% risk of predicted mortality after isolated valve surgery. Let's assess her echo. This transgastric view shows the location of the jet, which is mostly between the anterior and the septal leaflet. This tricuspid valve has 3 leaflets. we see a prominent anterior leaflet, and we will fully understand why in a few slides. We have an RV inflow alpha view with a biplane and the color showing the main location of the jet. We have right atrial dilatation, mild dilatation of the right ventricle without any decrease in monodimensional, bidimensional, or three-dimensional function parameters. There is a dilatation of the tricuspid annulus with a 40 by 34 millimeters, and the perimeter of the tricuspid annulus is 12. If we move the biplane a little bit more towards the center of the valve, in the next slide, we see that the jet is mostly, again, coming from the AES coaptation line and the center of the tricuspid valve. This slide makes clear that we have a mixed disease, so it's both functional and with some degenerative components. We see a prolapse of the anterior leaflets, which causes this severe eccentric tricuspid regurgitation jet, which is directed towards the septum. We also see
there is an endemic rupture cord now.
Yeah.
We just come out of a live case from Mainz where there was almost exactly the same anatomy.
Yeah, it's a complex anatomy. If we come back to the patient presentation, your patient is not that an old one, 74, so it's okay. The RV function is good. So I heard a lot of time that we should intervene earlier to make sure that we can get a more sustainable result for our patients, a greater improvement. And my very first question, and this goes mainly for the echocardiographers. Are there any echocardiographers here in the room? So feel free to grab a microphone and answer that. It's all about the evaluation of the tricuspid regurgitation, because we say, okay, we understand that if we propose a treatment earlier with a moderate or severe tricuspid regurgitation, not the torrential one, maybe we're going to get a better outcome if we intervene. But first question, how do we analyze that? Is it enough, the transthoracic echo or the transesophageal, as we do on a regular basis, or do we need something else? And when do we analyze that? Because we can clearly understand the impact of that prehabilitation that we apply to the patient, and we've seen that for the live case. The regurgitation was less at the time of the live case because the patient was treated aggressively. So my first question, do we have the right tools? If anyone is able to answer, wants to answer that, maybe Victoria, you can provide your feedback. And my second, the timing. Do you pre-ab aggressively the patients before analyzing the TEER and make your decision?
I think that first, once the patient has a symptom, you need to do the transthoracic echo to quantify, or at least to grade the tricuspid regurgitation, see the size of the right ventricular and right atrium and the inferior vena cava. And then perhaps if it's not on treatment or not optimized, try to dry as much as possible the patient, because you will see then the true function of the right ventricle once the patient is dry. And that's something that was questioned before, whether there is a risk for mismatch later on when you close the tricuspid valve or when you remove the tricuspid regurgitation. So that's first. And then for suitability for the treatment, I think the transesophageal echo is a must, because it's going to help you to see the views that you are going to use for the procedure. But for evaluation, first do a transthoracic echo when the patient is symptomatic, optimize treatment, and repeat it once the patient is as dry as possible.
Is it what you do, Federico?
Yeah, obviously, I didn't show the transthoracic echo because of time, but that was how the first diagnosis of severe tricuspid regurgitation was done. I just put the transesophageal images, and these were also the images at the time of the procedure. So the patient was on full diuretic dose by that time.
Francesco wants to say something.
So no, I want to engage Ali because he's the heart failure on the stage. So so we are asking for early treatment. This is early. I think we all agree. It's early because the patient has only 50 milligrams of Lasix, which is, something we start to think is already a lot, but still not incredible. Patient is low risk for surgery also, and never had a hospitalization. That is one point I'd like to ask you, because we know that actually when we think about the next trial, we would like to enroll patients with previous hospitalizations to get more events. On the other hand, so you could say probably it's too early. You could. On the other hand, there is a lesion, and that is not going to change with medical therapy. It's a ruptured chorda. So what would be your take? I mean, in your practice, is this something you should, potentially you can control this patient for some time, or what? What would you do?
So I think that clearly this patient has a mixed disease. It's not just secondary TR. This is looking like primary TR. And our approach would be associating the patient's symptoms to the lesion. And I think already we see the patient's on furosemide, which is an indicator that this patient's probably suffering. If we were to perform the right heart catheterization, I'm sure the cardiac output would be low. In this patient, there will be a lot of blood going in the wrong direction, and that will be reflected on low cardiac output. And then we would take this patient to our multidisciplinary meeting or heart team meeting. And then I think there will be a good debate about whether this patient should have surgery versus transcatheter valve surgery, transcatheter valve procedure, because the TRI-score on this patient indicated 2% mortality. We know with transcatheter valve interventions, the risk of procedures are lower than 2%. So I think there'll be a debate about durability of the intervention that would be discussed in this patient. But I think most of us, having had the experience now of transcatheter valve intervention, would proceed to edge-to-edge repair on this in this patient.
And that answers one of the questions from Nassim Braik from the audience about how do we integrate. We do integrate the TRI-score. So you mentioned the TRI-score in your decision-making as a heart team and to refer potentially the patient to surgery. So Wojtek, I saw that you were getting close to the microphone. We all agree that potentially it's likely that the patient is going to get a TEER procedure. I don't want to disclose anything, but it's likely.
Yeah.
What about the procedure? What would you do for this patient?
Well, I think with the, in our hands, when there is a limit of the number of procedures we can do, we probably would more strongly be for surgery, or at least discuss this, because we have more severe patients to treat as the first, as in the first line. But also in contrast to the MR, what we assume is the best medical therapy is actually only increasing the doses of diuretics. We don't have any other, maybe SGLT2, because my feeling is that those medications may help, like for every other type of heart failure. But I think that all we can do is to increase the diuretics, and this is not really a solution for this problem. Yeah. So I'm for treatment of this patient early, but it depends also on availability.
Let me say that something about surgery, because how many surgeons are here?
Are there any surgeons in the room?
Now,
oh my goodness!
So as a surgeon, I would not be afraid of treating this patient. It is a typical feedback of a surgeon. But besides that, I would say that we have seen now it's already 10 years we do TEERs. And I have to say, not all hospitals do it well. So that's why I get number of referrals from referring physicians asking me, please do surgery. Which means, and again, this is not the audience with referrals. There are no referrals here. These are all operators. I think at EuroPCR we should really convey the message, you want to do it well. Because otherwise you kill the business. What I see is that there is a kind of pulling back of the community in case of patients who are still eligible for surgery. So that is happening, and I think it's really because We have some centers who are not doing procedures at the highest level. So concentrate on doing good job.
We need to learn the techniques and the proper strategies based on the various variability of the anatomy. So having said that, the anatomy of the patient, Tiffany, before we come back to you, Federico, let's say that the patient is going to get a TEER, a TriClip. What would be your approach for this case?
Thank you. Yeah, so it's a really nice case. As you were saying earlier, it's mixed degenerative and functional. So that does add some challenges in terms of the leaflet quality, but the leaflet length looks very reasonable. In the transgastric, it looked like it was mostly anteroseptal. So just use my standard approach, would be starting the anteroseptal common. I think it would probably need potentially more than one device, depending on what device you use. And I'd probably, as a standard, use an XTW here.
XTW to start with, yeah. AS. And we're going to see if you go PS as well on it.
Let's see. I have a couple of slides of procedural planning. Obvious general anesthesia, percutaneous echo-guided right femoral access. We need 2 punctures. The idea is to use transesophageal and ICE. Obviously to perform a tricuspid TEER with a TriClip. So this is the idea. First, 2 clicks expected, XT or XTW, starting with an XTW between the A and the S leaflets, then reassess, and in case, place the second TriClip posteriorly to the first one. So the strategy that Tiffany outlined, and which is fairly routine strategy for TEER. So I don't know if there is any point in discussing, or maybe we jump directly into the live case. Okay, so this is the live case, echo-guided puncture. I added this 30 seconds because I think this is very important, and I want to particularly remark the importance of echo-guided access also when you do multiple sticks at the same level. Pre-closure with a prostyle, and then we go up in the SVC with a stiff wire. You already see the ICE probe in the right heart, and we advance the SGC. We take away the dilator. We advance a little bit in order to steer away from this Eustachian valve. We correct the steering in order to have a nice coaxiality with the superior vena cava. At this point, we advance the XTW TriClip, which gets fully out of the catheter onto its straddling position. Then we steer the flex, and we direct towards the tricuspid valve. First thing, we want to get the trajectory right and the location of our TriClip right. So we see in transgastric that we are at the level of the jet. Also the trajectory seems nice. We open the XTW clip. We go back to transgastric to orient to decide the correct clocking of the device. We give some slight counterclockwise rotation in order to match perpendicularity with the coaptation line. At this stage, we advance the device below the leaflets. We pull back the TriClip, and once we have the leaflets onto the arms, we drop the grippers. We check the insertion of the leaflets. The transesophageal was super good in this case, so probably no real need of ICE, but in this case we grasped using the ICE images. You cannot use them both at the same time, so we recorded this leaflet insertion on ICE, and then we evaluate on transesophageal. We see the septal leaflet is long. We have some color coming from the area, some other residual color close to the clip. So the decision was made to optimize the insertion of the leaflet. To do this, we obviously unlock the clip, we open the arms, and then we rotate the clip, you see steering clockwise towards the septum in order to move the clip towards the septum. At this stage, we pull up the gripper arm. You see how more of a septal leaflet we are inserting into the clip right now. We drop the gripper here on the right image, and then we close the device while simultaneously taking away the tension on the delivery system. We reassess now. The result looks pretty good. We don't have any major jet coming anteriorly. If we had any residual color anteriorly, we would have obviously moved the device more towards the AES commissure. This is not the case. We are happy with the result. This is why we proceed to do the unlocking and the release of the TriClip. This is obviously, it's important to check on color the result after the release. Something might change. We are pretty happy with this result. We see some minor color from the area, and this is obviously before and after. This is not on the left image. You see the baseline color, and this is after one single TriClip. So, are we done?
Maybe we can pause here.
Yeah.
So, who was in the audience experience with Tricuspid TEER? Raise your hand. So, from those who are already operators, would you stop here and accept this superb result? Raise your hand. End of the procedure. And for the other ones, would you continue? Raise your hand, just to see. So the vast majority would stop here, would accept this result. So maybe we can just pause for a couple of seconds. And Tiffany, you said I'm going to start AS. You've seen the result. Do you accept that, as the vast majority of our friends here would do, or would you be slightly more aggressive?
So yeah, it's a fantastic result. I really like that. Really nicely performed as well. It's always hard, isn't it, to know whether or not to put a second device in terms of stability. The leaflets are very mobile, but it looks like there was quite a lot of leaflet insertion, good tension, and it's an XDW. So although I tend to often put a second device in, I'd probably need a bit more reason. There's no residual TR here. There's good leaflet insertion. So I think I would probably stop here.
Because there is still that discussion, I know, Francesco, you like that, about that posterior septal region. Do we do something on that area, or do we leave the patient? Because there is still the option to come back at the second procedure, if needed.
Yes, but in this case, I think the main component has been the flail leaflet. So obviously, on one side, I would say, I mean, I'm just answering a bit superficially. We don't see the whole picture, but I would tend to stop here because of that. There is also a negative potential consequence of a second device that you can distort. You can, if you go towards the anteroposterior commissure, this is already pretty central. If you keep going towards the anteroposterior commissure, you might stretch the tissue and induce an additional jet. So probably I would stop here, but let's see what has been done.
There has been a lot of discussion in the cath lab whether to stop or not. So it's not easy to kind of convey all what we measured and assessed and evaluated into the cath lab. We felt that there was still lots of, let's say, movement in the clip. It was, at least part of the disease was degenerative, so we wanted to stabilize our result by adding a second clip just immediately posterior to it. And this was the point of discussion. I mean, we assessed, we were unsure, and then decision was made to stabilize. Look on fluoro how the device is mobile on the top left image, and even if we didn't have lots of echo residual color, we decided that, you know, stabilizing this could enhance the future outcome of this patient. Also, the gradient was super low, so we felt really comfortable with this. You see, we basically same steps as before. We advanced the TriClip, we orientated, we advanced it below the leaflets, we try to match and place it parallel to the other one, and this is done by fluoro and echo. And again, here you see nice anterior leaflet insertion, and also we go for septal leaflet grasping. Second clip is usually more straightforward unless you obviously have distortions, as Francesco was pointing out. And this is the result that we have after closing the second clip. We check also on transgastric to see that our leaflets are nicely going into the clip body. And we are happy with this result, so we release our second implant. And this is the fluoro, still some movement. We pull the ProGlide to close both accesses, and I will try to show the final result, which is more easily shown on slides. We have, again, this good color image showing that we basically do not have a significant residual jet at the level of the clip. There is that super tiny posterior septal jet. 3D confirms a nice positioning of the two clips. Thank you. And again, that's the minor residual posterior jet, mean gradient of 1, and we like to estimate the effect that we had on the annulus. This is the pre-TEER annulus with a diastolic of 50 by 42 and an area of 16.5 square centimeters, and post-clipping we had a moderate reduction in the diastolic area of maybe 15 to 20% with a 14.5 square centimeter residual area. And that's all I have for you.
I would like to one point about stabilization. First of all, it's good to second clip has been improving, I think, the annuloplasty effect, and also we say stabilizing. It's very important, in my opinion, to clarify that in this case, I don't think there would be a problem of detachment. You see this kind of movement if you have a flail, because you have one leaflet which is elongated, and therefore in systole tends to move in the plane. The second clip is not actually stabilizing; it's grasping more tissue, and then it's doing this annuloplasty effect and blocking the movement of the residual leaflet which was left behind. Which means basically the first clip was also only treating the flail, not treating the annulus. The second one has been treating the annulus. So at the end, good combination.
Yeah, the outcome is fantastic for this patient. You talked about the gradient, because one part of the evaluation of the outcome during the procedure and the fact or not to go for a second clip or to release the second clip is to analyze the gradient. So the question to you is, first, do you monitor the right atrial pressure real time during the procedure? And second, if you monitor the gradient, what is the threshold that you would consider as a limit to deploy an additional device?
So in terms of gradient, anything above 3 would be very suspicious and potentially not lead to the outcomes we want for the patients. And yeah, we have a monitoring of the right atrial pressure because our anesthesiologist likes to have the central venous catheter, and he attaches the pressure. So that's how we evaluate it.
And last question, maybe, Victoria.
But do you use it? So okay, you have the numbers. I don't know how to interpret.
Exactly.
A lot of these patients don't have the wave. A lot of these patients don't change the RA pressure. In the left side is clear cut. You really need to have it, and it's guiding decisions. In the right side, I'm lost. If anyone tells me you have a solution, please, I'm happy.
We need data. more.
With data. Yeah, this is very academic. He's becoming a chief president of academia.
And perhaps from the imaging point of view, do you use in every single case an ICE catheter, even if it's not 3D? Do you see the value in the edge-to-edge repair, or for other procedures perhaps more?
I see. I like to have it. I don't always rely a lot on it, but in some cases where you maybe have some shadowing, you have a mitral prosthesis, you have thick septum, you have an aortic device in position where you might have shadow, it can help with evaluation of leaflet grasping and insertion. So I like to open and place it in the patient if possible, and I find it useful in, let's say, not the majority, but some cases.
Yeah, sometimes it's very difficult to know how much tissue is grasped, and probably the ICE catheter gives you the clue. So I think that we are going to move. Thank you very much, Federico and Marco. I think that this first part of the session put really the emphasis on the, I would say now, omnipresent valve, because it came before the mitral valve. Usually it comes later or forgotten, but not anymore. And I think that we have learned that we need to refer these patients earlier, have a much more detailed evaluation of these patients for potential transcatheter or surgical solution before it is a point of non-return. And once you are at the cath lab, transesophageal echo and ICE also can help very much to define the final result. So I think that we move now to the mitral valve.
Yeah. So we understand a little bit more about the tricuspid, and this is really good, but there is still the mitral that is another challenge. So to kick off the first part of this session, we have a poll that maybe we can show you on screen. So there is a question that is going to pop up, and you should be able to answer it, because it's all about gathering your experience and your feedback about the type of patient that you would consider for a treatment or referral for a MitraClip. So there are several options, so feel free to answer. Use your app. So a heart failure patient and a functional mitral regurgitation greater or equal to grade 3. Heart failure and FMR greater or equal to 2. And asymptomatic FMR greater or equal to 3. Asymptomatic greater or equal to 2. COAPT-like patient, we're going to discuss that. Reshape HF2-like patient. And the last one, the really end-stage heart failure patient with a severe regurgitation. So please use the app and answer that. And maybe I can start with you, Wojciech, while the audience is reflecting on this question. In your experience, in your practice, we are talking now, Francesco is saying that I love the data, but I really much more enjoy the daily practice and the real patients that we are treating. And what is the type of profile of patient that you refer or you consider for a mitral TEER?
Right, so those are the patients who have the guideline-directed medical therapy. We changed a lot, and we observed that those patients referred for MitraClip 5 years ago or 8 years ago were completely different. So the improvement, symptomatic improvement, was immediate. And now we are having patients taking all the guideline-directed medical therapy, and those are a little bit different. I think, for me, they are a little bit less symptomatic, but this is only my guess. So I think we all like to have the COAPT-like patients because their chance of improvement it's higher for other patients. But I would say that at least 50% of patients referred and then treated are a little bit outside of the class 2B, I would say, patient.
So here, all together in the with the audience, what the feeling, the general feeling is that we are still treating patients symptomatic with heart failure and a significant functional mitral regurgitation. Also, we do also consider the COAPT-like patient, and maybe some patients, for 50% of us, with less of a degree of regurgitation. So let's see what we can get from the literature, and it's Vlasis and Ninos who's going to drive us through the way Reshape HF2 and COAPT have impacted our practice and what we can learn from these trials.
Thank you, Didier. So the question is, how does the Reshape fit into the post-COAPT era? And clearly, we have all seen our practice being in a bipole, in a binary dilemma, whether we should be treating an individual patient, whether this patient is aligned with COAPT or MitraFR. So this has been driven by the data that are clearly very conflicting. We're all aware a huge benefit in the COAPT-like profile and a neutral outcome in the MitraFR patient. And of course, various theories have been proposed for that. The most dominant is the proportionate versus disproportionate MR, and this has been going on for the last 6 years. So we've all been treating the COAPT-like patient. The guidelines have been aligned with this, but is that the whole story? Reshape came, and I was pleased to see that half of the responses were aligned with this in the poll. So it was a large multi-center investigator-initiated randomized trial, included 505 patients with moderate to severe and severe mitral regurgitation, secondary mitral regurgitation, symptomatic heart failure despite GDMT. And you can see the contribution and the paper in the New England. And is that really a tiebreaker, or is it a different population? Clearly, we can see that some of the elements in the demographics of these patients have been similar to the other two trials, but there are different differences. This was a low-risk population with an annual mortality of around 12%, lower mean EROA, so less mitral regurgitation and less NT-proBNP. However, there was a significant benefit in the combined endpoint of recurrent heart failure hospitalization, cardiovascular death, and also a significant improvement in the quality of life of these patients with improvement in the KCCQ and NYHA and 6-minute walk distance. So the benefit was substantial and very difficult to ignore. Now, if we look into this population and we put these 3 columns here, clearly there's a less severe mitral regurgitation, 0.23, compared to COAPT and MitraFR. But most importantly, the LV volumes of MitraFR have been substantially larger, whereas Reshape HF2 and COAPT had similar, a little bit more in the Reshape HF2 cohort. The rest of the demographics have been, and the patient characteristics have been pretty much the same. So why does Reshape matter? First is a real-world-like population. So patients come early in this group. The results are aligned with COAPT, but in a wider inclusion spectrum. It is certainly the first contemporary randomized controlled trial post-COAPT to reaffirm the benefit. And it has broken, in my opinion, the COAPT on nothing mindset. So the bipole is no longer there. And it has challenged the MR proportionality theory. So if you look into the proportionality curve, MitraFR and Reshape are proportionate in the degree of mitral regurgitation. COAPT is disproportionate. But we do see benefit in the Reshape HF2 as well. What we do observe even in this graph, your Reshape HF2 population has got smaller left ventricular and diastolic volumes compared to COAPT, and probably that matters quite a lot. So is it a time to change our mindset? Because in 2019, only COAPT-like patients get a MitraClip. Now, following Reshape, perhaps we can go to intermediate LV dilatation and intermediate MR severity and treat earlier, achieving fewer heart failure hospitalizations. So the key clinical message from Reshape is that it confirms that secondary MR is modifiable. It reinforces the concept that it's a therapeutic target, not a bystander. It validates early and proactive intervention. It broadens our treatment scope beyond the COAPT patient, and we no longer need to debate whether treating MR helps, I think, but we need to focus on who we're missing. Thank you very much for your attention.
Thank you very much, Vlasis. I guess we're going to see a couple of cases, and then we're going to integrate you into the discussion. And the cases are about illustrating how do real-life patients fit into these ReShape and COAPT studies. So Miriam Kessler is going to present the first case. Meanwhile, while she's getting to the lectern, maybe Ali, you've seen the ReShape HF2 trial. What does it generate in terms of comments from your side?
Great. So I think it's very welcome news. I think it just indicates that we have a group of patients who are probably less advanced in their heart failure. The degree of mitral valve regurgitation was a median EROA of 0.23 centimeters squared. The regurgitant volume was around 32 ml regurgitant volume. Very different to COAPT, where it was around 60 ml. And strikingly, the results show that there's a significant improvement in the KCCQ above 21 compared to COAPT, where I think the improvement was around 18. So there is a significant improvement in the quality of life of these patients. And also, this is in a shorter follow-up period time where they weren't able to show a change in mortality, because the follow-up time was affected by COVID, and the follow-up time was around 18 months, 18.8 months, versus COAPT, where we have up to 5 years data. So maybe there's time to demonstrate mortality with further follow-up. But importantly, hospitalization reduction is very, very significant in this population of patients. And the number needed to treat is around 5, which is very, very striking, and also adds value when we look at quality of life and also cost. So I think it's very welcome news, and I think this, in my practice, we are more likely to intervene sooner.
Nice.
And then the other aspect is the fact that mitral valve regurgitation has a dynamic component to this in the heart failure group. So depending on the volume status of the patient, loading conditions, these sort of factors play how mitral valve regurgitation can be dynamic in this group of patients.
Thank you, Ali. So please, Miriam.
Yeah, dear ladies and gentlemen, dear colleagues, it is my pleasure to present to you a case today with long-term follow-up after TEER. A 69-year-old male patient presented to our heart failure clinics with shortness of breath, New York Heart Association class 3, and repeatedly requiring IV diuretics. The patient has a history of coronary artery disease and had coronary interventions and a chronic total occlusion of the right coronary artery. The patient also has Hodgkin lymphoma. The patient has highly elevated NT-proBNP levels, which were around 21,000 for quite a long time. After up-titrating the GDMT, it dropped to 13,000. The patient also has chronic kidney disease with a GFR around 30 milliliters per minute. Here you can see the pre-procedural echo. The patient has, of course, severe MR, which you can see on the left. The patient also has significantly reduced left ventricular ejection fraction to around 30%. He also has a dilated left ventricle and concomitant severe TR. There's also mild aortic regurgitation, and in the right heart catheter there was postcapillary pulmonary hypertension. You can also see that the wedge pressure is clearly elevated to 29 millimeters of mercury with a prominent V wave, further supporting the significance of the mitral regurgitation. In the TEE, the MR was graded 3 and has predominantly functional etiology. You can also see that there are deep segmentations in the posterior leaflet in the 3D echo, and this segmentation also contributes to the mitral regurgitation. There's also a small ruptured cord, which you can appreciate at the bottom of the slide. So our plan was to perform an edge-to-edge repair. We wanted to place one device in a central position, A2, P2, with 12 o'clock clocking, so we don't open up the segmentations in this patient. So the procedure was then performed, and this was in 2020. So we planned to use one MitraClip XTR. So this is the third generation of MitraClip we were using by then. And at this point of time, it was not possible to do an independent grasping we are now all used to, but rather only simultaneous grasping. You can see that I struggled a bit with the posterior leaflet because the tip of the leaflet was rolling, and also the anterior leaflet is quite long, but in the end we achieved good leaflet insertion. We also stick to our initial plan to put one central device, as you can see on the right, and there's only mild residual MR left at the end of the procedure, which mainly comes from the segmentations I meant before. So after 1 year of follow-up, the patient was only mildly symptomatic, and we also had only mild MR after 1 year. This persisted through the 3-year follow-up with, again, New York Heart Association Class 2 and only mild MR. And even after 5 years, the patient was now asymptomatic with New York Heart Association Class 1 and mild or even trace MR. Regarding heart failure, the left ventricular dimensions and also volumes decreased over the time gradually, and also the left ventricular ejection fraction increased to around 40%, altogether indicating left ventricular reverse remodeling. Regarding the NT-proBNP levels, as I said before, they were highly elevated at the time point of the TEER procedure. They gradually decreased over the first 6 months to around 900 after 6 months. At the same time, the GFR and the renal function was stable. So what did we learn from that case? Before MTER, guideline-directed medical therapy, up titration is crucial as the patient tolerates it. So again, the keyword prehab. And despite some unfavorable factors in these patients, like the very high NT-proBNP levels and also the chronic kidney disease, MTER led to sustained symptom relief in this patient after 5 years, and also sustained MR reduction. And in the end, we also induced left ventricular reverse remodeling. Thank you.
So thank you very much for sharing this case with us. And there is one question coming from the audience about the follow-up of the patient. And did you look at the AP anterior posterior reduction of the mitral annulus during follow-up? Did you see a kind of continuous remodeling at that
also of the annulus, yes. I don't have the values with me, but it was not as pronounced as the reduction of the left ventricle.
And what about the tricuspid regurgitation?
Yes. So usually we don't do a simultaneous procedure, so no MTER and TTER combined. And we usually wait for a few months to see what happens to the tricuspid regurgitation. But this also decreased over time and got better. And the patient did not have any symptoms, no heart failure, hospitalization. So this is why we didn't do that. But we closely follow up this too.
Perfect. I have also another question from the audience. Maybe Blasis can answer, or Ali. How do you interpret the finding that in reshaped heart failure to study patients with a left ventricular end diastolic volume pretty large were the ones benefiting most?
Tough one.
It's a tough one because... Is that working?
Yeah.
It's a tough one because I'm not aware of any subgroup analysis in terms of the left ventricular dimensions, to be honest with you, but the median volume was similar to COAPT, a little bit higher, so it wasn't the excessive dilated LVs that were treated in the COAPT, and probably that's one of the reasons why the study was successful.
Also, in the heterogeneity analysis, the only factor that was really important was the previous hospitalization. So patients who came to the hospital were more likely to benefit than those patients who had no hospitalization.
And it can be also, depending on the number of patients that were in that subgroup, and we should go deeper into the etiology of that heart failure, which could be non-ischemic, and these are the patients that may benefit as well most with more reverse remodeling. So these are all very good questions that will need more analysis. There is one question there.
Yeah. Do you think adding assessment of the left atrial compliance will explain the presentation of some patients with recurrent heart failure, and will explain the outcome in these patients? Left atrial compliance and stiffness.
Probably in those patients that have the HFpEF etiology, and particularly those with atrial functional mitral regurgitation, these are the ones where probably you can assess the left atrial compliance. And specifically, perhaps in one subgroup of patients, as it was in this one, if they had Hodgkin and radiation, the left atrium can be stiffer, may not dilate that much, and that be a kind of other disproportionate group where less mitral regurgitation can give as much symptoms as patients with more severe mitral regurgitation. But these are kind of more anecdotal cases. But certainly in those patients with a preserved ejection fraction, this could be a good one. Anyway, if they improve clinically, does it matter very much in terms of selection? I don't think so. It's a very academic, good question, but in terms of the management, I don't know if that it will impact much. Maybe Ali?
Yeah, I totally agree with you, Victoria. I had a question for Mirjam with regards to this patient. Do you think this patient's heart failure medication were adjusted throughout the post-procedure period? And do you think that could have also helped the remodeling aspects of this patient's echo and also NT-proBNP levels falling? Do you think there was capacity and more room to further optimize medical therapy because an TEER was performed?
Yeah, thank you very much for that question. I totally agree. Medication is a very important factor for the remodeling. Actually, our usual approach is to up-titrate the medication after TEER, which is most of the time possible. In that particular case, I have to admit it's the opposite. So this patient didn't really tolerate the GDMT so good. He accepted it for 3 years, and after 3 years, he gradually got rid of the medication. So in the end, after 4 years, he only had beta blockers and no MRA or Entresto or anything like this, and still got the remodeling.
It's good news.
Okay, so I think that we have to move on. Thank you very much, Miriam, for the excellent case. And now it's the turn of Stefan Baldus, who will present another secondary mitral regurgitation patient treated with MitraClip. Perhaps more challenging?
Well, I don't know whether it's more challenging. It's definitely less attractive. So I was given this task of showing a more mediocre case after treatment of a MitraClip. So we had to go back and look at the patient who was first sent to us 7 years ago. He was an ex-high school teacher and had a 6-year history of cardiomyopathy, diagnosed in 2012. He had no coronary artery disease. He had apparently familiar history of cardiomyopathy and significantly depressed LV function. And he was New York Heart Association class 3. he got the workup, which is obviously required. So he had a mutation, a genetic cause of his cardiomyopathy. And he had atrial disease and electrical disease, and this was taken care of, given that he was undergoing intervention, pulmonary vein intervention, and ICD implantation. He was under sinus rhythm, and he was diagnosed for the entire course of his disease for mild mitral regurgitation. But he was symptomatic, and that's why he was referred to us. Here you can see the dilated and enlarged ventricle, and this mitral regurgitation, which was classified as mild. So he was under the concurrent medical regime for systolic heart failure. We used an up titration, so to say. So we ended Ramipril and gave him sacubitril valsartan as well as vericiguat. And doing so, one has to consider what is Entresto or what is sacubitril valsartan actually doing with respect to the degree, the extent of mitral regurgitation. And I think this is important. It does something. This is the randomized trial showing a reduction of mitral regurgitation in the presence of prescription of this drug. But the delta of EuroA is 0.04, so it's really a minimal reduction of mitral regurgitation you can receive by afterload reduction with this drug. So with this, we then said if the patient continues to have symptoms, and this was 3 months after initiation of this extended therapy, we then chose, even though it wasn't severe mitral regurgitation, treatment of the disease. And you can see and appreciate, I guess, that this was, as we still believe, relevant disease. So what you see here is a standard procedure with one generation 3 clip implanted here. And on the lower right, you see the residual result. And well, it's a question whether this is acceptable. We considered it acceptable at that time and left it as it was. So patient was discharged with this result, so mild or trace mitral regurgitation. So the patient was lost to follow-up. He didn't see our clinic for 2 years, and then came back 2 years later and again complained of shortness of breath, which was slightly aggravated. And these are the results who now show indeed an increase in the residuality of mitral regurgitation we've just seen during the initial procedure. So the patient, however, was under recurrent atrial fibrillation and had atrial tachycardia. Our electrophysiologists, given the extent of increase of the left atrium and the long-standing cause of disease, decided to not undergo and send him for another pulmonary vein ablation, but he in the end received AV node ablation and resynchronization therapy. What you can see, however, is that over the course of the next year, the extent of mitral regurgitation didn't diminish. And he was considered refractory with respect to his disease on the mitral valve. So we considered him a candidate for another TEER procedure and implanted a second clip, an anti-clip here next to it. And you can appreciate, obviously, the extent of mitral regurgitation is lower, but again, it's not entirely absent. However, the patient resolved somewhat from New York Heart Association class 3 to 2, and in the end basically presents with a stable disease under optimal medical therapy. The ICD is limited in its stimulation efficacy given ventricular extrabeats. As you can see here, there is even now, and this is the latest follow-up we have of this patient, slight increase in the residual MR we initially observed. So taken together, I think it's an example of a patient who was referred too late, even in the absence of severe mitral regurgitation. One could speculate if we had intervened earlier, in this patient, we may have had a chance to basically alter the course of the disease in this patient. Thank you.
Excellent case, Stefan. And you put the point for the question from the audience that how long do we need to wait for medical therapy to show reverse remodeling? And perhaps this is for you, Ali. Sometimes we see these patients, we keep them in the outpatient clinic. How long or how fast do we need to do the up titration of the medical therapy? And if no improvement, refer to intervention to avoid cases like Stefan has shown?
Yeah, so in our practice, and also based on clinical data that has been published, usual time frame is between 3 and 6 months. So, for example, patients presenting with a new diagnosis of heart failure, reduced ejection fraction, a time frame of 3 to 6 months is given to demonstrate remodeling. I think in Stefan's case, very interesting, the patient had a mutation, so this would indicate that they may have progressive cardiomyopathy and progression of their LV disease. So I can see why the patient may have developed further dilatation and perhaps further worsening of ventricular function reflected by an increase in mitral valve regurgitation. So I think the key is 3 to 6 months of medical therapy, very close supervision by the heart failure team. And then if there is still persistent mitral valve regurgitation, and in our practice, if the ROA is above 0.23, then we start looking into the mitral valve regurgitation in more detail to see whether they're candidate for TEER or not.
Yeah.
So Tiffany, we have we all now all together understand the value of referring the patients a little bit earlier, intervening while the mitral regurgitation is not torrential. The potential value of the TEER procedure to allow for more up titration of the medication. But the key thing, and we were discussing that with Francesco, is how do we convince the referring physicians? And do you have a special strategy to expand your reach outside the interventional community? Maybe Tiffany, and then after, then you after.
No,
yeah, Tiffany.
We can do a joint response. It's challenging. It's very challenging, as you know. It's all, as a concept, I think it's very important to optimize heart failure therapy pre, but then to make sure the patient carries on the medication post as well, because we've had a few cases where, again, lost to follow-up, maybe not the scenario in Stefan's case, but where purely by them not taking their medications, we make a really good situation quite bad, and that's very bad. It's also education on a patient level. As for referrers, it's difficult to convince our referrers, I would say, just being completely honest. Most of our heart failure team do have buy-in, but it's the external hospitals that we need to convince, and really it's just through education, presentations, discussions. I mean, because the data's there.
Thank you. You want to share your, go to the lectern, and then you can provide your answer to this point. But I believe that there is something that initiatives that may be obtained or carried out just to expand our reach, because it's really about educating the entire community and the referring physician, general cardiologists, because they have the patients, and we know that we have the therapy to treat these patients, but we need to see these patients.
So before we start, I would like to make a poll in the audience. Who thinks that MitraClip does not work in heart failure? See, this is the problem. This is the problem. So raise your hand if you think it doesn't work.
No. So
they gave you already
consensus.
Food. They gave you already food. You can say no. Well, that is the big elephant in the room. We are all convinced here. And the problem is why the rest of the world is not convinced. There are many reasons and many limitations. And it's not only the failure of the community, it's also somehow the failure of ourselves. We have been doing a lot of mistakes in the past, probably focusing on the index procedure rather than the full journey of these patients, and understanding that this is a community effort. It's not happening in the cath lab. It's happening before and after. And the road to success, I think, involves a number of factors. And before I start, I think PCR is, and this is a basically supported by Abbott, which is always supporting atrioventricular valves initiatives. We will start now a PCR focus group on mitral. And it's a bit strange because this was initiated for tricuspid many years ago, 6 years ago, when tricuspid was still at the beginning and there was a lot of confusion. And you might question why do we start mitral, which is there since 20 years now. And basically because the same level of confusion happens in mitral interventions as well. We have seen a lot of changes happening. When we published the first registry, I was a co-PI of the Access registry back in 2013. We published this data. 70% of TEER procedures were in heart failure patients. Today, I don't think we reach 50-50 with DMR. We see more and more DMR patients. So why? First of all, we need to build awareness in the community. This is a clear problem. We still debate whether MR is a culprit lesion or is just an indicator of severity. We still have to work on early detection. Still, to some extent, echo maybe not be the first line diagnosis in heart failure patients. There is a recent publication that says you should not even measure ejection fraction in heart failure because that is not so important. So my fear is that maybe they will not even do echo in a heart failure patient. They will start immediately with Entresto or whatever is coming next. I think we need to do more in terms of profiling these patients. We put everything in a single bucket, and to some extent, I think this has been one of our mistakes. Heart failure is there is FREF, FPF, there is atriogenic ventricular, there is AFib, there is patients in different status of their journey. We need to then adapt our discussions to the profile. So we claim, we're discussing about EROA. So is this number so important? And is it important in all subcategories? So we need to learn how to personalize interventions and obviously after that how to optimize guideline medical therapy specifically for these procedures. There is no single trial dedicated to medical therapy after optimization of MR. We talk about uptake ratio, but there is nothing there. So one reason I wanted to share with you these slides really is that I think we need to empower this community to talk to the other community, which is outside of the cath lab. And we are concentrated on the intervention, but I think a lot has to be done before the intervention. We still claim, it should be done earlier, but earlier means that you need to convince that you should not wait until the heart is gone to treat these patients. Now, we have some evidence, and that is, I think, what we should probably, I'm talking to Abbott yet now, what we should do a bit different in the future. We should think about how to empower this community with the right methodology to inform those who are not experts that actually there is data. There is new data which is coming out, and we understand, for instance, from the expanded registries that you reach reverse remodeling only in those patients who have a small heart. If you treat patients who have a very dilated heart, no reverse remodeling, so no effect on long-term outcomes. Reshape 2 has been another important publication, another important trial that shows that severity of MR, disproportionate proportion, all this numerology around the degree of regurgitation is failing. What counts is more a complementary and comprehensive assessment of heart function, but also about the syndromic of heart failure. Heart failure is not only pump. And so treating patients with less than severe MR, if they are symptomatic, has been associated with improvement of quality of life and reduction of heart failure hospitalizations. So this is a slide that comes from a publication we are preparing together with many heart failure specialists, say that overall there is a decrease in the threshold to indicate for interventions, which doesn't mean really to me that it doesn't work in very severe MR. It tells you that probably the degree of MR should not be the number one driver for the indication. This is a big mistake we've been doing all these years. Managing patients with moderate FMR in heart failure makes sense for a number of reasons. And number one reason is that actually these are the ones where we can be more effective, but also because once you don't treat the very end-stage patients, you can achieve much better outcomes. But also we need to think a little bit differently about how we position this therapy. In my opinion, the number one reason why we should do this procedure is because these patients may become more compliant to medical therapy in heart failure. This is not a solution. We are not giving the solution. When I talk to my patients, I say, okay, I'm gonna treat you not to take out drugs. I'm gonna give you more drugs. And that was not the case when we started. So that is the second thing then. So we talk about earlier indications, but also we should really care about long-term management and post-procedural management. I think in heart failure it's very clear today the concept of 4 pillars. The concept of 4 pillars is based on the idea that it is better to implement 4 pillars of medical treatment all together, okay? It's a matter of complementarity of different therapies. So we should force the idea that we can put a 5th pillar in case of structural disease, which will collaborate with medical therapy to improve outcomes. And the idea here, in particular when we talk about secondary MR, is that we are not treating MR. We are improving compliance to medical therapy. Many of these patients are not compliant because of hypotension. And even in those trials where they show compliance to therapy, you never know whether these patients are really taking these pills. Most of them, they measure their pressure, they skip the therapy because they feel like dizziness or they have too low pressure. We know that acutely we improve cardiac output, acutely we improve systolic blood pressure. We need to keep working on that. So up titration has been demonstrated somehow, or let's say shown in some retrospective data to be beneficial. Really, we need to work all our efforts in this direction. I think up titration is the key element also for the acceptance in the heart failure community, because we are not telling that we are stealing these patients from their care. We are just helping our heart failure colleagues to treat these patients more efficiently. There are 2 papers that you need to read and you need to refer to when you talk to your colleagues, to your referrals. One is a paper from Mariana Damo showing that the up titration following treatment has been associated with a reduction of mortality and freedom from other events. But there's also now the Ocean Mitral Registry from Japan showing similar outcomes with beta blocker up titration in these patients. So there is some initial data suggesting a benefit. So in conclusion, why the community does not really engage after 20 years? It's a mixture of factors, and we really need to be more educated to how to speak with the community which is working outside of this room.
Very good. So let's see if at least the community from here is convinced to put the message outside. So we have a poll question for you all.
It's the
so
same.
If you can answer now the question in your clinical practice, which 3 patient profiles do you prioritize for treatment of referral? Let's see if we can echo what Maisano has said, and we also put the message across the other professionals that deal with patients with heart failure.
Yeah, after the reshape HF2 data. So does it impact your practice? Meanwhile, there was maybe a question for Stefan about this case, about the fact to potentially refer the patient for heart transplant. Was it considered, or?
Yeah, this is a great question. But the patient at first presentation was 67 years old. We do not get any transplantation in patients above 65 in Germany.
Thank you.
Okay. So if we can see the votes.
Yeah, it's not a dramatic change. More or less, it remains the same distribution with a lot of really symptomatic patients with a great massive regurgitation, but also COAPT was second, and now it's more the reshape HF2-like patients who are more considered. So interesting. So let's see how it's going to evolve in the future, but it's we follow the data, and it's more and more data to support our practice. So I guess it's time to conclude, Victoria.
Thank you, Didier, and thank you, the speakers, the discussions, and the audience for the good engagement. I think that the main message of this second part of the session is to engage professionals outside the cath lab that are dealing with patients who have complaints of shortness of breath. Do an echo. If you see mitral regurgitation, you see heart failure, put the 4 pillars, but remember that a mechanical pillar is also important in order to correct the disease that is causing the symptoms. So go out and send this message.
And
thank you.
And thank you, Abbott, for